Welcome, welcome. I'm Dr. Alan Jacobs of the Arthritis Center of Nebraska, and I'm glad you came on this nice spring day. It could have been snowing, of course. So we're going to talk about osteoarthritis tonight and try to tell you about how it differs from one or two other forms of arthritis. And that's not how you spell my name out on the screen there, but I wanted you to know that I have an internet site, and so you will see some videos tonight and some information. And if you are connected to the internet with a broadband connection, what you see, you can also go to my site and also see it there. So if you miss something or if you want to share it with a friend, you can direct them to my site. Now, osteoarthritis is the most common form of arthritis by far, so that 90% of all people's visits to doctor's office is due to osteoarthritis when you tally up all the visits for joint or muscle problems. So clearly it far outshadows rheumatoid arthritis, psoriatic arthritis, and lupus. So it is so common that it's sometimes just called arthritis. So they don't use the word osteo in front of it. The part osteo means bone, so you can interpret this as meaning the bone against bone arthritis or the bony spur arthritis. So that's what the connotation of osteo means. But it's also called degenerative arthritis or degenerative disc disease of the back, and it's just sometimes called bone-on-bone arthritis. So there are a lot of different names, and so it can be confusing for people to understand which form of arthritis we're talking about here. But these are all equivalent names. Now I'm going to show you one of the videos I prepared, and I mentioned my name on it, but that's because it's meant to be shown on the internet. And so this one will talk about the definition of osteoarthritis and what it actually means on basis of x-rays and pictures of a joint.
Did you know that osteoarthritis is the most common form of arthritis? This is Dr. Alan Jacobs. Osteoarthritis is a disease that causes the breakdown of cartilage in joints, leading to joint pain and stiffness. It is also known by many other names such as degenerative joint disease or just plain arthritis. In normal joints, a firm, rubbery material called cartilage covers the end of each bone. Cartilage provides a smooth gliding surface for joint motion and acts as a cushion or shock absorber between the bones. In osteoarthritis, joint tissue first becomes pitted and frayed, loses its elasticity. With time, large sections of cartilage may wear away completely. As a result, the bones rub against each other, causing pain. As the bones rub together, the joint may lose its normal shape. The bone ends thicken and form bony growths or spurs. Also, fluid-filled cysts may form in the bone near the joint. Bits of bone or cartilage may float loosely in the joint space. All these changes can create pain when the joint is moved. To diagnose osteoarthritis, physicians start with your medical history and physical examination. X-rays and MRIs can be done to confirm the diagnosis and determine how much joint damage is done and help rule out other kinds of arthritis. Blood tests are normal in osteoarthritis. Do not confuse osteoarthritis with osteoporosis, which is a bone disease that causes bones to break very easily. Rheumatoid arthritis is also a lot different from osteoarthritis and is not a degeneration, but an attack of the joint by the immune system. Osteoarthritis can affect any joint, but it commonly occurs in the hips, knees, and spine. It also commonly affects finger joints, the joints at the base of the thumb, and the joint at the base of the big toe, called the bunion. It affects the wrists, elbows, shoulders, ankles, or jaw less often. In the spine, osteoarthritis starts out as degenerative disc disease, as seen by an MRI, and with time, the typical osteoarthritis X-ray changes begin to appear. If you have prolonged pain in your joints or your back, I would encourage you to have your problem evaluated. This is Dr. Alan Jacobs.
So any questions? Is that pretty much old information for you, I hope? So that's the definition of osteoarthritis, and sometimes in the office it is a little complicated for us because a person can have more than one type of arthritis. So like in a knee, for example, you can have both osteoarthritis and a rheumatoid arthritis attack in the same knee. So we have to use special tests to kind of sort it out, which form of arthritis is bothering that particular joint. It could be a gout attack in the toe, and that toe may also have osteoarthritis in it as well. So there's no rule that says that you only get one type of arthritis, and so at times it can be quite complicated. Now, the causes of osteoarthritis. Primarily, it's going to be due to age and inheritance. And when I talk to people in the office and I see osteoarthritis, I always ask them, are there relatives that have the same type of arthritis? And the answer is yes, most of the time. So inheritance has a strong bearing on this, although the scientists haven't figured out one particular gene. So there's probably multiple genes, so it is hard to predict who in the family might come down with it if mother had it, for example. But certainly age is a characteristic of this arthritis, so we do not see this in young children and 20-year-old kids, and we might start seeing it in some individuals who are 30, but before that it's not an arthritis that we typically see. It can be caused by trauma. If you injure the surface of the joint, it doesn't repair itself very well, and then with time the joint will break down and have maybe a bone-on-bone condition, such as the football players who injure their knee and 15 years later they have to have a knee replacement. So, but it can also be from chronic daily overuse. So in farmers and factory workers, I see hand joints that are basically worn out. You can tell that was years and years and years of using their hands, and they can overuse the joint so much that they've permanently injured their joints just from their daily use of them. And then you can get osteoarthritis, but it can be caused from some other form of arthritis. And rheumatoid arthritis, for example, if the attacks have been going on severely for many years, the immune system damages the joint, and if that process is treated and goes away, that joint, because of that damage, will slowly change and deteriorate as time goes on and form an osteoarthritic joint. So osteoarthritis can be an aftermath of rheumatoid arthritis and psoriatic arthritis and a number of other ones. So again, it can be complicated because people can have two forms of arthritis at one time. So the scientists don't know the exact cause on a microscopic level of what is actually going on, but it is a failure of the cartilage cells to repair and rebuild the cartilage. So they just don't do a good enough job, or they cease to function prematurely in life, and the cartilage has nothing rebuilding it, and therefore the cartilage begins to degenerate and forms pits, and then at the end result can be totally gone. It's kind of like our roads here in Lincoln. If the repair crews didn't come filling the potholes every spring, yeah, our roads would be like osteoarthritis, I guess. So we lose our smooth surface as this process goes on, and it's a failure of these cells, and the scientists are trying to focus in on their research to see if anything can be done to stimulate these cells to grow new cartilage and therefore cure or prevent osteoarthritis from occurring. Right now we don't have that ability. Now, osteoarthritis can begin in a number of different ways, but the majority of people who have osteoarthritis, it occurs so slowly over time that they don't have pain from it. And so many joints have osteoarthritis and there's no pain. They complain more of stiffness because the joints don't move as well, but they don't get attacks of pain if it occurs very, very slowly. And so there's most cases of osteoarthritis that don't need to be treated because there's no pain involved. And so that's a distinction. Now, other people, it occurs rapidly, especially in the hands, for example, the fingers, and then it becomes very painful if it occurs very rapidly in the fingers. So after the osteoarthritis has been present in both the rapid, painful form or in the slow form, after a number of years, the joints all look the same. So you can't tell how it may have bothered that person in early life. So most of the time, slowly, with lots of stiffness, and a lot of people may have osteoarthritis in their whole body, but they only have one sore joint, like their knee, but they have it all over their body. So it's a blessing that we don't suffer from each and every joint that has osteoarthritis. Now, whoops, let me back up. Now, so what are the reasons that a joint may have pain? Well, there's a number that I could think of. First of all, it's mechanical. That is, you have, let's say, a joint that's bone on bone, and when you just rub the bones together, like walking, for example, the bone doesn't like the lack of protection. The bone is not meant to rub against the bone, and there are a lot of nerve endings in the bone, and you'll know it because that's a very abnormal situation when you lose your buffering tissue. Mechanically, there can be pain because like in the knee, for example, there is the meniscus, which is that thin rim of cartilage that goes around the knee, and that always becomes degenerative and has a lot of tears, and sometimes when it's torn, it gets in the way and gives a sharp pain when a person tries to walk, or it may cause the knee to feel unstable and may cause a person to fall. And the tears in the meniscus occur silently unless there's a torn edge that gets in the way and prevents the normal functioning and motion of that particular knee joint. There can be inflammatory reasons for the joint pain. This mechanical irritation in the knee causes a festering reaction inside the knee, and the scientists do see the inflammatory cells inside the joint, and so this inflammatory process produces molecules that stimulate pain, and so inflammation can cause pain, and you do find inflammation in some cases of osteoarthritis. The pain can be referred to the surrounding tissue in that particular area. So the surrounding ligaments and tendons can feel pain because they're trying to compensate for the bad joint, and they may be overstretched, for example, or the inflammation inside the joint spreads to the surrounding outside tissue, so there can be soft tissue pain around a joint that has osteoarthritis. And also, especially in the spine, the surrounding tissue that causes a lot of pain when there's spinal osteoarthritis are the muscles. So there are a lot of tender points and muscle pain and tension in the areas of the spine, all the way from the neck down to the lower back. So a lot of the spinal pains are actually muscular in origin, but the muscles are just reacting to the arthritis in the spine. But by treating the muscles, the pain can be relieved to some extent. And so understanding that can lead to an avenue for finding some pain relief if that happens to be the case with surrounding tissue having pain and inflammation. And then there's the growing spur, and maybe some of you have had those bumps grow on your fingers. And when they occur suddenly, they turn fiery red and they get swollen and they hurt like heck. And so that when they turn red and inflame like that, that's associated with the spur growing very rapidly. And there's something very painful with that. And so when people have the redness and swelling go away, there's a bump left in the finger, and that's the spur that has grown during that process. And fortunately, in most people, those attacks of fiery red pain in the fingers last from 2 to 6 weeks, and then it disappears, and mostly I think because the spur has stopped growing, and so the pain is relieved just by trying to wait it out. And so, but sometimes the pains are throbbing, and they may even keep people awake at night. So those are the different mechanisms for pain, and there can be some of these all at the same time. So there can be mechanical origins of the pain along with inflammation within a joint, or you can have all of these go on at once, and so that it's actually complicated to figure out the exact origin, but these are helpful in understanding that process, because then we try to offer therapy directed at the possible cause. So when we say there's a flare in osteoarthritis, I like to understand what kind of flare is going on. Is it a mechanical flare with broken material? Is it inflammation? Is it the surrounding tissue and so forth? Because without understanding that, the right kind of treatment cannot be administered very well. So the next, we're going to have a video that talks about conservative measures that you can do to take care of your joint. And when we talk about treatment, this is always first and foremost. And so medications and so forth are not the first thing that should be considered. These are the first things that you'll see in a second. And unfortunately, it does require a person to adapt a little bit different lifestyle and to do something special that have been out of the routine. But arthritis does demand that changes be made, since it's not a curable condition. So you'll recognize some of these. Some of these are very old, like using splints and so forth. But pay attention to this, because this is the starting point of all treatment.
Osteoarthritis is a degenerative process of the joints and spine that leads to loss of joint cartilage, and it may affect any joint in the body. It is a permanent condition that causes pain when a joint is moved. This is Dr. Alan Jacobs. The key to living with osteoarthritis is to modify how you use the affected joint. Exercise is very important, but not every exercise is healthy. Walking with osteoarthritis is okay, provided the weight-bearing joint is not very affected. Limited weight-bearing exercise with a stationary bike or water exercise is often preferable. Weight reduction is a great idea and often essential. There may be specific strengthening exercises that may benefit a joint, especially the knee. The time-honored application of cold or heat may be useful. At times, the joint and spine need to be protected from overuse. Some people benefit from the use of a splint, such as those for the knee or thumb. The spine may benefit from a neck collar, lumbar brace, or use of a lumbar support. There are various options for the feet, including shoe inserts, and these can be very helpful. There are very many assistive devices that can improve function and also reduce pain with certain activities. Many of these items can be found on the internet. As people age, muscle strength and balance may decline, and assistive devices for ambulation are very important in preventing people from falling. Other professionals may be able to help you with osteoarthritis. Massage therapy may help reduce pain along the spine. A physical therapist can help you strengthen specific muscles that will help protect the joint with arthritis. A podiatrist can provide various types of help for the feet. An orthotist is a certified professional that can custom make certain splints and braces. All of these conservative measures should be considered before trying any pain medications. This is Dr. Alan Jacobs.
So some of these things have been around for centuries, and but they are needed. But we do have to listen to our bodies and adjust the things that we do, and take the pressure off of the affected joint. What I see too often is people think all exercise is totally healthy, and people go out and do the wrong exercise and make themselves a lot worse, and may have damaged the joint even more by doing the wrong thing. So exercise is vital, but it has to be the right kind depending on what joints we're talking about. Now, a lot of people have seen others with canes, or you have family members who might use a cane. And so I had developed a cane video a while back, and people are surprised to know there's a right way and a wrong way to use a cane, and there's different kind of canes. Some canes are for balance, and so those are the single point cane just for balance. But the weight bearing canes are the 4-prong canes with a flat handle. So if you're going to have to put weight on a cane, it should be of that sturdy nature, one that's not going to tip over. So different kind of canes, and I think this should show you how to use it. So again, only you can take care of your joints. And we mentioned the splints already, the thumb splints, the foot splints, the wrist splints, the unloader braces for the knee, and the various canes and walkers. So if you have some questions about these, you can come up to me after the talk, and we'll go over some of it in private conversations. And again, more splints. These are just the things available at like Walgreens, and they have back supports and ankle braces and thumb braces and all kinds of things that might help a person eliminate the pain with the use of a joint. So here's the cane video. So you use it opposite to the bad joint. So if you got a bad left knee, you use it in your right hand. So this is a bad right knee, and she uses the cane in her left hand, and you swing the good leg through. So, and the purpose of that is so that you walk level. You don't walk tilted, because pretty soon you'll get back pain. So here she is again, and she's swinging her good leg through and using the cane opposite to the bad joint. So we'll show you a picture about the height of a cane, and the purpose of using a cane this way is to not tilt and cause a new back pain. So this one's too long. She didn't want it. She'd been using it for years, but it caused her to bend her elbow too high, and that's too long. And it does take practice to use a cane, and so it's not a natural feeling. It's not natural at all to learn how to use the cane properly. But the proper height is if the hand is down here, and so it just kind of fits snugly into the palm at about this level. So that's the correct height. And so if I had a bad left knee, then I would put the cane down with my bad leg at the same time, put some weight in my right hand, and take half the weight off of my left side, and I swing my good leg through. So you get the rhythm of doing it, but people do have to practice, and it's really, we see so many people coming in, and they've caused themselves problems by using the cane incorrectly. And so now we'll go into the treatment, which I think you probably want to listen to, and we'll probably have most of our questions about the treatment of osteoarthritis. And so this video will go through many of the highlights, and we can talk about some details afterwards. I hope.
Osteoarthritis is the most common form of arthritis and leads to pain when a joint is moved. Conservative treatment measures should always be used first when trying to find relief. This is in order to avoid medication side effects. This is Dr. Alan Jacobs, and I want to mention some of the medications and treatments that can be used. There are no medications that can cure or prevent osteoarthritis, but the treatments can help reduce your symptoms. There are treatments you can try yourself, including various liniments and also tablets of acetaminophen, which is also known as Tylenol. Be careful to read the instructions on the label so that you do not take too much of it. Acetaminophen is considered the safest medication for pain. If there is not enough relief, try ibuprofen, which is also known as Advil, or naproxen, which is called Aleve. Again, follow the instructions on the label, and if you have significant health problems, better consult your physician first. If these don't help, the prescription version of these arthritis pain medications, called the NSAIDs, may be given to you by your physician. As this slide shows,
there are many to choose from. Not one of these can be stated to be better than the other. A few can be used just once a day, and others are used 2 to 3 times a day. It may be worth trying several of these to decide which one may suit you best. But the NSAIDs may have side effects, ranging from a burning stomach to an actual stomach ulcer, changes in kidney function and increased blood pressure, liver reactions, rashes, hives, asthma, increased bleeding, especially when people take Coumadin, also called warfarin, or Plavix, and also increased fluid retention called edema. The risks of these medications goes up with age and the number of medical problems. Very often, plain prescription pain pills work better and are safer than the NSAIDs. These pain pills may include tramadol, also called Ultram, propoxyphene, also called Darvocet, and hydrocodone, also called Vicodin or Lortab. If injection therapy is done correctly, it should not cause pain. As you can see from this slide, almost any joint can be injected, and it is therefore a very versatile form of treatment. The most common joint that is injected is the knee. Some joints may contain a large quantity of fluid that may also cause pain, and removing this fluid by a needle aspiration may quickly reduce the discomfort. Removing the fluid is best done under the guidance of an ultrasound machine. The fluid can then be sent to a lab for diagnostic help if needed. Joint injections are very safe when compared to taking oral medications and often reduce the pain in 24 hours. For most joints, the material that is injected is a combination of an anesthetic like lidocaine combined with some form of cortisone. These types of injections have been used for decades and can be repeated every 3 months if needed. If cortisone is given into the knee and does not help for 3 months, then a special injection can be used that is often called joint grease or joint oil. The special material may often last 6 months or longer. There are various products that are now available. These products can vary in terms of how many injections are required and range from a single injection to 3 weekly injections to 5 weekly injections. If the pain and lack of function is severe and constant, the last resort is a joint replacement. The knee and hip are the joints that are most often replaced in order to be able to walk again. Unfortunately, recovery can be slow and there may be complications. This is Dr. Alan Jacobs, and I would suggest that you discuss all of your treatment options with your physician in order to decide what best suits you. Okay, so the guiding principles when you use medications to treat the pain of osteoarthritis is that you should always try the safest and the most conservative measures first. And traditionally, that has been with the suggestion to try acetaminophen or Tylenol first, but not take a high dose. By and large, it has the fewest side effects and the fewest serious problems when taken properly. So acetaminophen is still recommended by the American College of Rheumatologists as one of the first things that people should try on their own. And then as the video mentioned, you can then, if that doesn't work, you can try on your own, if you're in good health, ibuprofen or naproxen, those types of products, and follow the label and see if they help you. As always, when you think the pain might be gone, it's important to go off the treatments and don't just take them forever. I've seen that done even with the prescription medicines, that people get in the habit of just taking the medicine and not seeing if they need it anymore because they may have a type of temporary osteoarthritis pain that doesn't require interventions. So when we use the prescription high doses of these NSAIDs, they should be continued only when the person taking them is thoroughly convinced that they have value in terms of pain relief. So it's not the health provider or doctor who says you have to take it. You're given the opportunity to take it, but it's your decision if it's something you want to stay on and it has enough value, because there always will be some risk in staying on it. So in our office, we take those risks very seriously, and if a person finds relief, well, then we see them and check lab and try to safeguard them against the hazards of being on these types of medications. So the older a person gets, the more significant are the side effects. And so the Geriatric Society suggests that we try to avoid these medicines completely in individuals getting to be 80 years or older, and I agree. I think that there's a lot more side effects the older the individual becomes, and that has a lot to do with the thinning of the stomach lining, or the kidney function has been reduced by age, and then the kidneys don't handle this medicine well, or they may have congestive heart failure, and these medicines can make the congestive heart failure worse. And a lot of people are already on the blood thinners like the Coumadins and so forth, and we should not use these medicines because of excessive bleeding. So just to have a good respect for these medications, and these are listed on that handout, and also if you have the ability to get on the internet, they are again listed there, so you can always go to my site and share that information with somebody else. So they're not to be ignored. What bothers me sometimes is I see patients who have been evaluated elsewhere, and they're elderly and they have a lot of medical problems, and the medications are started without checking a few lab tests first to see if it's okay to use them. I always check the hemoglobin to make sure there's no anemia, because these medicines cause blood loss through the stomach, so you don't give these medicines to somebody who's already anemic, because you can easily make that worse. And I measure their kidney function, because if their kidney function is borderline or not very good, these medicines will shut down the kidneys. So you have to have a high respect, but when used under these guidelines, they can be used safely. So you have to have the confidence in the person administering them that they're going to help watch over you and do all the right things. But you can see here again, these are all the names of those medicines that are on your sheet, and so there's a whole bunch of them. And when they've tried to do a number of comparative trials of, let's say, 500 people, and they compare one versus the other in terms of pain reduction, they all pretty much turn out to be the same in terms of the level of pain reduction in a group setting. Now, that doesn't mean that every individual will find that they're all the same. There are definitely some individuals who will prefer one more so than another, because for some reason we don't understand, it works better for that particular person. But my feeling is, after maybe trying 3 different ones, I don't think we're going to find one that will help if they've already tried 3 different kinds already. So it is worthwhile to try different ones, and at the minimum for 2 weeks. Some rheumatologists like to say 4 weeks of trying the medication, but in my experience, 2 weeks is usually long enough to see if it helps with pain. And when used in prescription doses, the medication stays in the system for 24 hours, and so it has little variation if used at their full dose, so that it's in the body day and night. Whereas the over-the-counter products people can take on their own, they're going to be removed from the system fairly quickly. So like a regular Tylenol is 4 hours, and Advil and ibuprofen is 4 hours, and Aleve is a little bit longer, perhaps 8 hours. So depending on how you dose those, it may not carry you around the clock. So there are some medicines here that are advantaged for those people who need 24 hours of relief. And currently, probably meloxicam is prescribed the most, because it is a once-a-day version of these medicines, just 1 pill a day, and it's also become very inexpensive, so that even people without insurance, they can buy it, usually afford it on their own when they go to the pharmacy. So meloxicam has advantages now of cost and also of great convenience to take. So so that's probably the most popular medication right now. Celebrex was developed to protect the stomach from ulcers and stomach bleeding. Unfortunately, that promise was not realized, so the company cannot claim that they prevent stomach bleeding or stomach ulcers. But it does seem to give people less kind of indigestion and soreness in their belly compared to some of the other ones. But that's about the most you can say about it. You can also say about Celebrex that it's the one that can mix with the Coumadin medication or the other types of blood thinners. So Celebrex does not thin the blood, whereas all the other ones, we assume, do. So there should be a definite role for Celebrex if people are on Coumadin for whatever reason, or perhaps even Plavix. And we try to avoid these other traditional anti-inflammatories if we can. Now, you all may have remembered Vioxx and Bextra, and maybe some of you have tried it through the years. And those side effects that were found totally rocked the drug industry, because ever since they removed Vioxx for having an association with strokes and heart attacks, it was totally unexpected. The companies would have to prove to the federal government that there's none of those side effects during their research. But to do a study like that would cost millions and millions and millions of dollars to look for rare side effects such as that. So there's been no release of any new NSAID for many years, ever since Vioxx was released. So all these medicines here, except for Celebrex, are off patent. They're all generic, all except for Celebrex. And I don't know when that patent will be out, but there'll be some generic company quickly making it, because there could be advantages if it was available at low cost. However, we find in the office there are a lot of insurance companies that refuse to pay for Celebrex because it's so high priced, and the original studies show that it didn't reduce pain any more than naproxen did or ibuprofen did. So the insurance companies, to save dollars, they make this contention. Now, the problem is, if some person really thinks the world of Celebrex and it works better than anything else, we just can't get the Celebrex approved for them, because nowadays the insurance companies are very adamant about not paying for things. So we can get them to pay if a person's on Coumadin. That's the one exception they tend to make. So, but someday the patent for Celebrex will go off, and I think there will be easy use of it. It might have advantages for people who have tender tummies, for example, and they can't tolerate anything else. So that's the story about Celebrex. Some new medicines have popped up, like this Duexis, which hasn't been on commercials yet, but all that is I think it's naproxen combined with a stomach medication. And so it's not a new medicine. They're just making 2 pills into one. You know, that doesn't excite me, because you could take the 2 pills separately at a much lower cost. So that's how the industry is doing things. So some of these medicines are getting so old that they may not be made much anymore. Our first anti-inflammatory, of course, was aspirin. Aspirin dates well over 100 years old, and so for decades, you know, we've used primarily aspirin. And across the world, the third world countries, aspirin is still the #1 anti-inflammatory or #1 pain pill in most countries, because it can be made for pennies. The history of aspirin is very interesting. In the days of malaria and chronic fever, and people were sick all the time with their fever, they were always searching roots and various things for medications that might break their fever and their suffering. So a lot of times people were sent out as guinea pigs to test this root or that tree or that plant, and they struck oil. They had success in the 1700s, where one of the foremen working for a large estate, he started eating willow bark, and his fever went away. So he's happy to report to the owner of the mansion that he had found willow bark as a way to reduce pain, and it also helped the fever. Well, the world of chemistry was not very sophisticated, but there was progress made in the late 1800s. And chemistry was getting enough so that they could identify the products in willow bark and some other plants that were helpful. And so then they came up with aspirin in the late 1800s, and the Bayer Company was the first major manufacturer of any kind of medicine in the whole world. And so the Bayer Aspirin Company, which still exists and still owns the patent to the name Bayer Aspirin, is still making trillions of aspirin tablets a year, and they first started making them in 1898. So that was our first. And then it wasn't until the 1950s and 60s that the company started making some other ones, such as ibuprofen and Indocin, or indomethacin. They invented those. And then starting in the 70s, then we got to have a whole slew of them because they were all trying to make money, and so we have a whole pile of them. But that's the history of these kinds of medications. As our population has developed more and more osteoarthritis, there's greater and greater use of these kinds of medication, and then hopefully we get more benefit than harm from their use. But there's really nothing wrong with aspirin, other than it makes people bleed a little bit more than the other ones, but some people still prefer it for pain relief than other medications. So, but I guess it's not used very much for fear of bleeding, and especially bleeding within the stomach. So that's a little history about these anti-inflammatories. And again, I try not to use them in people over 80 years old if I can. Once in a while there's some really healthy 80-year-olds, and so they might tolerate them fine. Now, but sometimes in some people with various health problems or the elderly, just regular pain pills may be far safer than the arthritis pain pills. And so common pain medications were discussed in the video, but tramadol is an excellent one if it doesn't have any immediate side effects, because there doesn't seem to be any known long-term side effects. It certainly doesn't harm the kidneys or the liver, and it doesn't cause stomach ulcers. And so it's very, very inexpensive. So if we can't find a way to find good pain relief, tramadol is a consideration. And so people start off with a low dose, and then they can increase it to make sure they don't feel a little queasy or nauseated from it. But it can be a very useful medication. The video mentioned Darvocet. Of course, I made that video before Darvocet was removed from the market, so we don't have Darvocet. And I hear every week somebody who wishes Darvocet had come back because they really loved it. So that's too bad, because we used a lot of Darvocet. The hydrocodone and codeine products certainly have a role. Doctors in the past, especially 20 years ago, were afraid that everybody was going to get addicted to hydrocodone, but it's not really true. It's a very rare person who might have a susceptibility to hydrocodone addiction. And it's what we call a Schedule III controlled substance, so that it needs a special prescription, and it has a 6-month duration. But when used in limited doses, and the equivalent medicine might be codeine in some people, when used in limited amounts, people are not going to get physically dependent on it, in my experience. So, for example, like twice a day. And people with bad arthritis, especially in their spine, taking at night to help their pain so they can rest, and then they're so stiff in the morning, taking hydrocodone can help people get it moving, and the faster they can get moving, the better their arthritis pain will be that morning and the rest of the day. So I use the hydrocodone in the morning to get moving pill, so that they don't have to wait 2 hours to feel like they can move. They can get moving faster, and then moving will help their arthritis feel better. And so hydrocodone and codeine play a strong role, and when used properly, it can be helpful. The duration of the effect for these medications might be somewhere between 4 to 6 hours, so they're not going to last all day long. But I think the products that have been designed to last all day long, I don't always think in the long run work very well, and they cause problems. Most of the time people, eventually get immune to the ones that stay in their system 24 hours a day or 12 hours a day. And some of the products might be things like Oxycontin and Cadian and those kind of things. I don't like treating osteoarthritis with those kind of medications because they're greater chance they cause a physical dependency, and I think people just get immune to them. So more limited doses of milder pain medicine like hydrocodone have a great advantage in my experience. So there is a role because if used properly, they are safer for some people than the anti-inflammatories. Well, there's no rule that says you can't use them both if you need to. So if a person can take meloxicam, but they still need the hydrocodone in the morning and at night, that's fine. So we do whatever mixture that's safe to help person combat their pain and stiffness. So they can be combined in that fashion. Now the joint injections, depending on the person doing them, they should not be painful, okay? And I've had to have that talk with a lot of people who've had bad experience elsewhere because we give a lot of injections in the office, and there's a right way and a wrong way, and too often we hear the horror stories of them being done the wrong way. So there's a way so that they don't cause a lot of pain. And especially if there's fluid that has to be removed from a knee, for example. I have methods in the office where we use the ultrasound machine and we can see the fluid. We can very accurately take it out, and a lot of times people don't even feel anything at all. So there are ways to do this so that it's not a scary, frightening procedure. And so especially like for the elderly who can't take medications, the joint injections can be very helpful in pain control, and then we don't have to worry about what side effect are they going to get. And so if the regular cortisone injection lasts for 3 months or longer, if we need to, we'll repeat it every 3 months. But we don't usually schedule them except for certain times. But usually we just have the person call when they think the shot has worn off, because sometimes it lasts 5 months or 6 months. So we don't routinely administer it. We do it based on the pain. But we don't want the person to wait too long so that they've allowed the pain build up so much that it might be harder for the treatment to help them. So there's a strong role for injections in osteoarthritis. Unfortunately, when all these things don't help and a person has continuous pain and a very severe loss of function, then the replacement surgery is something that they have to consider. And it's a tough decision the older the person gets, because if they're in their 80s, they know that, well, it might take 6 months to recover, and that's a large chunk of their remaining time that they might have. And then the side effects of the surgery may go up with age, such as getting blood clots or having the heart, react, or getting infections. So a lot of people in their 80s need the surgery, and if it's a young, healthy 80-year-old, they'll do just fine. But it's the older person who has a lot of health problems where the risks go up. But surgery has gotten so much better that they've mastered ways to limit side effects compared to 30 years ago when I saw people in the hospital. There were many, many more complications with the way the surgery was done in those days compared to the way it is now. Like for the knee, for example, there's something called minimally invasive knee replacements. And so the surgeon doesn't cut through all the muscles that the regular surgery does, so that there's less swelling and less pain during recovery with that type of surgery. And so I've even heard of some of my patients going home without even crutches or a walker, because their pain has been helped so much by the surgery. So they are attempting to make the recovery time shorter, and so that's why they've experimented with this minimally invasive surgery. And all that means is they try not to cut tissue. If they can get the joint in there without cutting tissue, then the recoveries will go faster. And so there are surgeons who have done quite a few of these. So the recovery and the risk is a problem. And unfortunately, with some of the joint replacements, like for the knee, for example, even though the surgery worked out great, everything's in the right position, there's still residual pain. It's a new pain. It's not their old arthritis pain, but it's a new pain, and there's something about the metal rubbing ligaments and tendons, for example, that makes the joint sore. So that's why surgery is not recommended until the pain is really a lot, so that even if you get that post-operative pain on a chronic basis, it's still better than you were to begin with. So that's why there should be. That's why the surgeons often say, well, come back when you think you're ready, because it's not their decision to do the surgery. It's always your decision when the surgery should be done. So. So people who are getting relief with the medications or injections, they can continue to put off the surgery, but there might be a point where the arthritis just gets so bad that those things won't help, and then there's a time to consider surgery at that point. Okay, now we'll open up for questions in a bit, but I just want to mention that our Knowledge Night series, I think this is the third Thursday of the month, I think. So it's every third Thursday in the spring and in the fall, and there's a schedule that you can pick up if you're interested in attending the other sessions. And also, once again, a lot of the discussion and the videos are all available at my website, so that you can go back and listen to some of these things again if you'd like to.